Thank you so much. And as Dr. Peretta mentioned, we are both genetic counselors working at Huntsman Cancer Institute in the Family Cancer Assessment Clinic. And we see a lot of women and families who have an increased risk for breast and gynecological cancers. And that's what we're going to be covering today.
Okay, so I wanted to get started with some general information about cancer. So, about 1 in 3 women will be diagnosed with cancer at some point in their lifetime. It's a very common disorder, unfortunately. And as you can see in this little table, both breast cancer and uterine cancer are among the more common cancers that we can see in the general population in women, along with colon and lung and some thyroid cancers. So, we chose to talk mostly about breast and gynecological cancers as they do affect a good number of women. So, what causes cancer in general? The biggest circle here we think about is sporadic cancer. So, that's cancer that we don't really know why somebody is diagnosed. It could be a combination of environment, lifestyle, family factors, gynecological factors. A lot of different things can go into these sporadic cancers. But by far and large, most cancers, we just don't really know the exact cause of the cancer. There's a smaller circle where we think about it being familial, which means you might have a family history of, say, breast cancer. And so there might be some sort of familial breast cancer factors that are putting women at a slightly higher risk for breast cancer in the family, but maybe not a known genetic condition that's causing that. And then there's an even smaller circle called hereditary cancer. And that's where we do genetic testing. We find some sort of genetic marker that is causing cancer to develop in individuals. And it is more rare. Only about 5 to 10% of all cancers are due to one of these underlying hereditary factors. But that's really where we're going to focus a lot of our discussion today. So, when we think about someone's risk for cancer, there are a lot of things that go into that. And that applies to both breast and gynecological cancers. We think about somebody's age, their physical activity, potentially their weight, things like alcohol consumption, gynecological or reproductive factors. And then breast density can also impact breast cancer risk specifically. And that's something that shows up on a mammogram, not necessarily something that you can feel. There are other factors like family history and genetics, and all of those things go into a risk estimate. And we're again going to kind of be focusing on family history and genetics, but just know that there are lots of things that can also impact risk outside of these things. So here are some red flags that if you have a family history or a personal history, some things you might want to think about that could indicate there may be a hereditary factor in your family. These are things that the genetic counselor, like myself or Amanda, might ask you about in a visit. It would be things like breast cancer, when someone was diagnosed, if they were diagnosed young, say under 45, did they have breast cancer in both breasts or was it just one breast? Something like triple negative cancer, that's a more rare type of breast cancer. Someone with 3 or more family members on the same side of the family diagnosed with the same type of cancer can also be a red flag, especially if they're diagnosed young. Or somebody with specific ancestries, like Ashkenazi Jewish ancestry and a history of breast cancer in the family. So this image I have here is just showing an example family history. The BR stands for breast cancer and the OV stands for ovarian cancer. So you can see the circles here that are filled in. There are some women with breast cancer diagnosed pretty young, 36, 39, 42. There's some ovarian cancers, and there's multiple women in multiple generations. So this is a suspicious family history. Now, when we think about genetic testing, there are a number of genes that come to mind. We've known about BRCA1 and BRCA2 for many years. They are the most common breast and ovarian cancer genes. And often that's what you've heard of if you've heard of anything in the breast ovarian cancer world. And so we'll talk a little bit more about those, but there are also lots of other genes. There are high risk genes that can be related to breast and other cancers. There's kind of a chunk of moderate risk genes. And then there are some other newer genetic risk factors and even things we haven't discovered yet that can impact this hereditary risk. So there's lots of different genetic factors that can go into breast cancer. So more specific about the BRCA1 and 2 genes, this is a table that shows you kind of the most common cancers we think about for men and for women. On the right-hand column, you can see the general population risks. So somebody with an average risk for breast cancer is in the 10 to 12% risk, but somebody with a BRCA1 or 2 mutation might be more like a 45 to a 65% risk. And so it's much higher than that average population. Same thing with ovarian cancer. Most women are at about a 1.5% risk for ovarian cancer. And with a BRCA mutation, that might bump up to 20% in some families and up to 45, 50% in other families. And I know we're thinking about women's cancers today, but men don't get off the hook with these things. We can see a higher risk for breast cancer in men and prostate cancer in men with these two genes. And with BRCA2 specifically, we think about a higher risk for pancreatic cancer. So we can see multiple things going on in a family in somebody who has one of these types of genetic markers. This one is just to kind of show you a little bit more about those other genes that I mentioned. So there are lots of other breast cancer genes out there, and they all have a little bit different patterns of cancer. So some families, we might see breast cancer and stomach cancer, and we might be thinking about CDH1. Some families have breast and pancreatic cancer, and we might be thinking about PALB2. So there are lots of different things that we look for as genetic counselors in a family history. And you might not be getting testing for just one thing. You might be tested for all of these breast cancer genes to kind of look at lots of different types of risks.
And when we think about cancers of the reproductive tract, they can occur in a lot of different areas. And not all reproductive tract cancers are as likely to be due to an inherited factor as others. So, for instance, usually genetic assessment is recommended for any woman with ovarian or fallopian tube cancer, as well as women with primary peritoneal cancer, which is a cancer of kind of the lining of the abdomen, kind of around the ovaries. It acts very similarly to ovarian cancer. Women who have endometrial cancer under age 50 are also recommended to have a genetic evaluation, as well as individuals who have certain combinations of cancers in their family. So, breast and ovarian can sometimes run together, as Whitney mentioned, in families that have a mutation in BRCA1 or 2. As we'll see, we can also see endometrial and colon cancer running together in families that have a condition called Lynch syndrome. There are also certain very rare types of cervical cancer, including embryonal rhabdomyosarcoma and adenomalignum, which can be due to much more rare genetic predispositions. And kind of to touch on cervical cancer a bit, cervical cancer is a relatively more common gynecological cancer for women to have. However, the most common types of cervical cancer are usually not due to inherited factors. Some women do have multiple relatives who are affected with cervical cancer, but there tend to be other risk factors that can predispose to it that are not inherited, such as infection with HPV, the human papillomavirus, or smoking. Smoking can double a person's risk for developing cervical cancer. And researchers are actually studying whether genetic factors might increase a person's chance of being infected with HPV if they're exposed to it. But it's the action of HPV infection which is actually causing that increased risk for cervical cancer. And as Whitney mentioned, there are also a lot of different genes that we know of that can be associated with these increased risks for ovarian, endometrial, and other gynecological cancers. Of the number of gynecological cancers that are considered hereditary, the vast majority, about nearly, 75% or so of those cancers are due to mutations in either BRCA1 or 2 or Lynch syndrome. There are rarer mutations in other genes which can give an increased risk as well, including mutations in PTEN, which can give an increased risk for both breast and endometrial cancer, as well as BRIP1 and RAD51C and D, which can give a moderately increased risk for ovarian cancer. We certainly expect that there are other genes associated with hereditary gynecological cancer risk that science just hasn't identified yet. So certainly genetic testing continues to improve, and there may be other genes that we can test for, in 5 or 10 years. So when we think about Lynch syndrome, it is about as common as we see BRCA1 and 2 mutations. It occurs in approximately 1 in 300 to 1 in 440 people, kind of in the general U.S. population. It's caused by mutations in one of five genes. Together, we call them the mismatch repair genes. And as you can see in this diagram, Lynch syndrome can give an increased risk for multiple different kinds of cancer. The two cancers that it tends to give the highest risks for are colon cancer and endometrial or uterine cancer. Ovarian cancer kind of comes in around third or so, along with stomach cancer. These Lynch syndrome is a condition for which we not only have genetic testing, but we also have tumor screening for colon cancers and endometrial cancers. And here at Huntsman Cancer Institute, all colon cancers and endometrial cancers that are surgically removed here at Huntsman are actually screened for whether or not that tumor is likely due to Lynch syndrome as part of the surgical pathology workup. It uses a test called immunohistochemistry. While not a genetic test itself in kind of the classic definition of the term, it gives us an idea if this person's cancer may have been due to Lynch syndrome, and we can recommend additional genetic testing if needed. Some of the genes that confer a more moderate risk for ovarian cancer, specifically when there's a mutation, include BRIP1, RAD51C, and RAD51D. These genes kind of work together in the same pathway, and each of them gives slightly different ovarian cancer risks over a lifetime if that gene is damaged. However, it's roughly about a 10% lifetime ovarian cancer risk. Mutations in these genes may also be associated with an increased risk for a very rare type of breast cancer called triple negative breast cancer. However, a woman's lifetime risk for this type of breast cancer is typically low enough that even if it is slightly increased, currently no changes in breast cancer screening have been recommended for women who have mutations in one of these three genes. However, we do recommend intervention regarding the ovarian cancer risk. So, for women who have a mutation in one of these three genes, we usually recommend that they consider having their ovaries out to reduce that risk of ovarian cancer as much as possible between the ages of 45 to 50.
So this is a table we included to show you a comparison of risk numbers. So this blue, smaller, and I included breast and ovarian just as examples of this. The lower graph is showing someone with no family history. We know that women can be diagnosed with breast cancer even without a family history. Same thing with ovarian cancer. And again, that's about a 10% risk versus about a 1% risk. When someone has a family history, but maybe no genetic mutation, their risk can sometimes be doubled, sometimes tripled. It's higher than the average risk, essentially. So that's the second bar is here. When somebody has a genetic marker in one of those moderate risk gene mutations, their risk can range in the 20 to 40% risk for breast cancer, or maybe in the 10% risk for ovarian cancer. And then as a comparison, when someone has a BRCA mutation, that risk can be more like a 60% risk for breast cancer and a 40 to 50% risk for ovarian cancer. So there are lots of different levels of risk depending on what family history there is, what types of genetic markers, and people's different test results. So now we're going to transition into a little bit more about screening and risk reduction options that are available to women who may or may not have these family histories. Thinking about breast cancer risk management, this table shows some different risk levels and what we might recommend. So on the right side, you can see for average risk women, we say everyone should start a mammogram at age 40 and should follow up at least once a year with a mammogram. And again, that's because women, even without a family history, can be diagnosed with breast cancer. And so we recommend once a year mammograms and a clinical breast exam from your doctor. For somebody in kind of the middle range where they might have a family history or a moderate gene mutation, we might start them younger with mammograms. We might offer different imaging, or we might recommend medications to reduce risk. That's what tamoxifen is here on kind of the middle section, or they might be offered risk reducing surgeries depending on where that risk falls. And then somebody in the high risk category, again, we're going to recommend they start screening younger than the average population. We also might recommend different screening. So, breast MRI in addition to mammogram. We might recommend a clinical exam from a doctor every 6 to 12 months. And those women might have more options for surgical risk reduction or might be more recommended to take medications to reduce their risk. So, depending on where your risk falls, there are different options for you to both screen for cancer to find it early and as small as possible, or to reduce that risk altogether.
Yeah, and really the biggest difference with gynecological cancer risk management is that we currently don't have reliable screening for endometrial or ovarian cancer. Pap smears are recommended for cervical cancer screening and they are very effective, but they don't typically detect, endometrial or ovarian cancer. There's been a lot of research, particularly into, ovarian cancer screening methods, and there just hasn't been found something that reliably detects ovarian cancer at early stages at this point in time. So, because of that, for women who are at an increased risk, particularly those who have a specific mutation that's been identified in their family that gives them a very defined risk for uterine or ovarian cancer, these women are often spoken with about risk reduction options rather than screening options. So, one method of risk reduction that can be considered is medication. We know that women who take oral contraceptive pills for at least 5 years or more usually cut their risk for ovarian and endometrial cancer about in half. Those 5 years do not need to be consecutive. And so that's something that women may have done for other reasons in their lifetime, but also provided them some extra cancer risk reduction in terms of ovarian and endometrial cancer risk. However, even with this level of risk reduction, for women who are at high risk for ovarian and endometrial cancer, we're typically still recommending that these women consider surgery to reduce their risk as much as possible. And that includes, removal of the ovaries and fallopian tubes or the uterus, depending on which organs are at risk based on that specific gene mutation. Of course, the biggest issue to consider if a woman is having her ovaries removed is the impact of surgical menopause. If a woman is having her ovaries removed when she is still premenopausal, she will then be automatically into menopause. For women who have not had cancer, taking hormone replacement therapy can often be an option for these patients, and it's something that they should explore with their doctors, before proceeding with surgery. There are different types of genetic testing available, as Whitney kind of mentioned earlier. For most patients who have not had genetic testing done in their family before, if there is not already a known mutation causing cancer in the family, usually we use a type of testing called a multi-gene panel. As we've seen, there can be a lot of overlap with what genetic mutations can result in different types of cancer. So, for instance, for a woman with ovarian cancer, it may not be clear from her family history. Does this look more possibly like BRCA1 and 2 compared to a BRIP1, RAD51C, RAD51D mutation? And so, because of that, most current genetic tests look at multiple genes at once. This is really helpful. It used to be that we could only test one or two genes at a time, which got to be, significantly also more expensive for patients. Now, multiple genes can be tested on a single test. This is usually the test that's recommended. As I mentioned, if you're the first person in your family having genetic testing regarding this type of cancer, and also, it could be recommended even if there is a known mutation in your family, if that mutation isn't really explaining all the cancers that have happened in your family, and there's a concern that there might be more than one genetic risk factor running in your family. It's an uncommon situation to occur, but it can happen sometimes. However, some people are recommended to just be tested for a single known genetic change in a specific gene that's already known to be present in a relative, such as a person's mom or their sister or brother. And so this is usually done when the majority of the cancers in the family could be explained by this factor or have been explained by this factor. It also can be recommended when, let's say, a relative with cancer in your family had a more comprehensive test, like a multi gene panel, and only that one single factor was identified. No other mutations were found in that person's relative. In that situation, really the most informative person in the family, the person with cancer, has already been tested. And so there may not be a need to test as many genes in other relatives.
So, as many of you know, we are now in an age where we have lots of access to genetic information through multiple different sources. So, there are multiple direct to consumer options for genetic testing. Many of these offer ancestry testing, but will also offer health screening options in addition to that ancestry information. So, we get a lot of questions on if I had a 23andMe test or one of these other tests, does that cover me for these cancer genes? And the answer is not necessarily. So many of these labs only report 3 common mutations that are more common in that Ashkenazi Jewish population. They're not doing full BRCA1 and BRCA2 testing. And so therefore, there are thousands of mutations that could occur in BRCA1 and 2 where we'd be missing the majority of those genetic mutations. They also don't necessarily look at the full spectrum of cancer genetic testing. So if you have more than just breast cancer in a family, that test is likely not going to be appropriate for you. It will likely miss things or not be as comprehensive as you want. So really with any family history of cancer, we'd recommend talking to a genetic counselor to see if there's other testing that would be relevant for you. The other thing we think about in a genetic counseling visit is who is the best person in a family to test? And the answer to that is really the most suspicious cancer, the person with the most suspicious cancer. So in this image, you can see on the right, there's one yellow apple growing in a tree of red apples. And if we want to know why that yellow apple turned yellow, we are going to test that yellow apple. We're not going to test the red apples to understand why the yellow apple became yellow. And that's the same thing with cancer in a family. If we want to know why the cancer in a family is occurring, we want to go to the people who have been diagnosed with cancer because that is the best chance for us to find an explanation for that cancer, which can then help the individuals in the family who have not been diagnosed. So a genetic counselor can really look at your family history and help you know who might be the best people to offer this genetic testing to.
And genetic testing, as Whitney mentioned, can be done in a lot of different ways. For cancer genetics, really the most comprehensive testing can be ordered by a clinician, whether that be a genetic counselor or physician experienced in genetic testing. It can be done using a blood or a saliva sample. Currently, since a number of clinics are seeing patients by telephone or video because of the pandemic, genetic testing can be done with a saliva sample with a kit that's mailed to a person's home. The saliva testing is actually just as accurate as the blood testing, as long as a sufficient enough saliva sample is provided. Genetic testing for hereditary cancer risk is now typically covered by health insurance if you have some of the risk factors for hereditary cancer that we've mentioned, present in your family history. However, if a person's health insurance company does not cover genetic testing for any reason, or if a person doesn't have health insurance, multiple labs do offer out-of-pocket prices of about $250. A lot of laboratories also provide financial assistance programs for individuals who may have very high deductibles or are in financial difficulties. They can submit paperwork to the genetic testing laboratory to see if they qualify for either a reduced price from that or possibly having the lab cover the cost altogether. We also get asked often about whether or not getting genetic testing might affect your health insurance or might affect your employment. There was a federal law passed back in May 2008 called the Genetic Information Non-Discrimination Act, or GINA. It's totally separate from the Affordable Care Act. What it does is it relates specifically to what health insurers and employers can do with genetic information. So, under GINA, health insurers are prohibited from using genetic test results to raise your rates, set your premium, deny you coverage, or prohibiting them from requiring you to get a genetic test in order to continue your health insurance coverage. With employers, as long as the employer employs more than 15 people, they are prohibited from obtaining or using genetic test results of their employees in any way in hiring, firing, or promotion decisions. Unfortunately, GINA does not apply, the protections of GINA do not apply to life insurance, long term care, or disability insurance. Some states are actually trying to advance bills to have to initiate protections regarding, say, life insurance and long term care and disability insurance coverage regarding genetic testing. However, most states, do not have that in place, at this point in time. So, typically, as long as a person, receives their health insurance either through a group policy or from a policy that they've obtained themselves through the marketplace, those health insurers, are all covered by GINA in terms of, prohibiting genetic test results being used against patients. Oops, there we go.
So just lastly, we wanted to review some of the resources we have at Huntsman Cancer Institute. We have a couple of physicians who specifically specialize in managing women with increased risks for breast, ovarian, and other cancers. So Dr. Sarah Colonna and Dr. Joanne Jeter are both a part of our family cancer assessment clinic, and they have clinics on Wednesdays and Fridays at Huntsman and or Sugar House Health Center. And it's really aimed to help women understand what options are available to them based on their family history or genetic test results. And if you want more information, a good place to start is thinking about genetic counseling. Obviously, Amanda and I are genetic counselors, but if you heard today's presentation and thought I have a family history of breast cancer and I wanted to ask somebody about it, we have a genetic counseling consultations available through Huntsman's Family Cancer Assessment Clinic. Our scheduling number is on there. You can call us for an appointment. We are offering telephone appointments right now, but also have the option for video or in person if that's preferable. And currently, this is a service that is not billed to insurance. It's a free consultation option.
And a lot of people wonder kind of what happens in a genetic counseling appointment. During an appointment, we will review a patient's, family history of cancer and their own medical history. And then kind of based on that, kind of put it all together and really discuss, your personal risk to have a hereditary cancer predisposition. The idea being, if we did genetic testing, how likely is it that we might find the cause for the cancer in your family? If genetic testing seems like it would be beneficial, we can certainly order that and interpret the results when they come back. But regardless of whether or not genetic testing is ordered, we can always provide tailored cancer screening and risk reduction recommendations based on either your family history of cancer and genetic testing if that's done as well. All right. And so now we definitely have, some time that we can take any questions. We can't answer questions today that are, say specific to your own personal or family history, but any general questions about the topic, we're happy to answer. And thank you very much.
I do see one question. I don't know if you want me to just jump in. It looks like someone asked, when would you see a high-risk clinic physician versus the genetic counselors, which is a great question. And at Huntsman, we generally have most people start with a genetic counseling appointment. We will collect your full family history. And then if we feel like a referral to a high-risk physician is appropriate, we can facilitate that referral. Sometimes it's nice to have genetic testing before you see those clinics. And so often we'll have you start with a genetic counselor and then we can recommend specific high-risk clinics that might be appropriate for you.
I think there's some additional questions. If you're at moderate high risk for breast or gynecologic cancer, which healthcare provider should oversee your risks?
That's a really good question, and if it's possible for, an individual to, come in and be seen by, Dr. Colonna or Dr. Jeter, that's a great place to start. Certainly not everyone, may live out of state or further away, may not be able to attend one of our clinics here at Huntsman. There's certainly other providers in, the Intermountain system that we can also refer out to. But kind of starting with a clinic that's associated with the genetics clinic can be a helpful place to start, and then they can give you recommendations to help your local gynecologist or primary care provider do some of that screening as well, if you can't be seen in that clinic kind of on an annual basis. But we often pull in other providers as well, such as surgeons, if a person is thinking about risk reducing surgery, or possibly a gynecologist to manage medication risks.
See a good question on when should children be tested for Lynch syndrome specifically, but potentially other genetic risks as well. And for the most part, we wait until at least age 18 to offer these genetic tests to kids, and that includes Lynch syndrome and BRCA. And that's simply because for most of these things, we don't see childhood cancers. They're things that we wouldn't change medical management until someone's in their adult years. And so it's really not helpful or relevant to a child yet. And we like them to have kind of that autonomy to make that decision for themselves. So for the most part, over age 18, there are some rare exceptions, but yeah, in general.
And that's also a great question about, how does risk on both sides of the family combine for a risk factor? And it's actually really interesting because if a person has, say, a mother and a father who both had, say, even the same or different types of cancer, we often think of that as less of a genetic risk than if you have multiple family members on the same side of the family having the same or a certain combinations of cancer. And that's because just having a single individual diagnosed with cancer is typically less suggestive of a hereditary impact than multiple individuals on the same side of the family. And so it really depends if you have, cancer on both sides of the family, we really kind of evaluate each side of the family separately. But sometimes that can help, let's say if there's a known mutation on one side of the family, but there's also a family history of cancer that's not been explained on the other side of the family, that might be a circumstance where a person might have testing with a multi-gene panel rather than just be tested for the one risk factor on one side of the family. And it is something that I always like to mention that, genetic risk factors for breast and gynecological cancers, those risk factors are equally carried by men and women. So we always look at both sides of the family when we're, really determining risk.
I know we're a little over time. I'm happy to answer the questions remaining, but thanks for joining us. If you have to hop off, there's been some really good questions. There is a question on genetic testing and cancer risk assessment. So how are they different? Which is a really good question. Genetic testing is kind of one piece that we use to do a cancer risk assessment. So we'll look at the family history, we'll look at your personal history, and then we'll look at genetic testing options, which can all together help us to know what are your risks for cancer and what might the appropriate screening for you be. So if you've had genetic testing, if you still have questions about what screening is appropriate for you, we'd be happy to look at that in combination with some of your other factors to give you kind of those more personalized recommendations. So they really are related, but work together in different ways.
And there was a question about, if you had BRCA and Lynch syndrome testing a number of years ago and they were negative, should you be tested again? And the answer is honestly sometimes. So BRCA testing and Lynch syndrome testing has definitely improved over the years. One of the main updates with BRCA testing was back in, oh gosh, I want to say about 2013 or so. It became more standard to include large deletion and duplication testing of BRCA1 and 2. Test results prior to that were less likely to have had that part of the test included. That only identifies an additional maybe 3% of BRCA1 and 2 mutations. So it's still unlikely for a person to, come back positive if they had BRCA testing now to when they did in the past, but it's possible. So it really depends on when an individual's testing was done. And if a person ever has questions, we're happy to look at that person's original test report and let them know if there's been improvements to that specific testing since they were originally tested.